I will review the articles about the classification system. It contains introduction, definition, goal, requirement, history and evolution, review article, summary, conclusion. The most common fracture site, according to more than half of spine injury, biomechanical weak for stress. The canal is narrow, this predisposed to spinal cord damage, resulting to 20 to 40% nerve deficit. In young patient, fracture occur due to high energy trauma. The old patient, minimal trauma can cause fractures due to the osteoporosis and decreased cognition. Definition of classification: the action or process to classifying something according to qualities or characteristics or observed similarities. Goal of classification: facilitating effective communication between treating physicians to develop a common language. In description of an injury configuration, the similar assessment in type and severity of injury, guiding management when the patient needs surgery. To allow for the development of global accepted treatment algorithm that would provide treatment recommendation for a wide variety of thoracolumbar injuries. Requirement for good classification need comprehensive, intuitive, simple to implement, can uniformly describe injuries, can be validated, predictive to outcome, and moderate or good reliability. Most of the existing classifications have failed to fulfill the above criteria. Some are oversimplified, while others are too inclusive and complex for routine use. Some classifications fail accurately determine whether an injury is stable or unstable. Let's see the history and evolution of classification. If you see, from beginning in 1929, Boller, and then 38, going to Nyckel, Kelly and Woodside, Horsford, Dennis, McAfee, Ferguson, and Hutton. The review article is this not applicable. And beginning of these changes of our classification in 1994, it stimulates further research about the thoracolumbar injury. And now, in the latest classification is thoracolumbar injury classification from Vaccaro and teams. And there is a modified of our modification. So there is only two classification is now widely used in the world. Thoracolumbar injury classification and modified our classification. Let's see the review article of the classification. I will explain this is a positive or negative conclusion. The thoracolumbar injury classification used frequently by doctor radiologists in order to categorize thoracolumbar fracture to evasive and appropriate therapeutic strategy. The most widely used classification system for patient with thoracolumbar injury. This positive statement attempt to assess the severity of injury and help the treatment guideline. This is the positive statement, but most of the statements is before the 2015. Provide the best availability predictor of surgical vs non-surgical management. Positive statement. And the reliability is high. Initial studies show good reliability and variability in terms of injury classification and treatment plans, although some of the studies were written by the developers of the system. Integrated kappa statistic of all subgroups were within the range of moderate to substantial reproducible, but this is from journal in 2007. Has an appropriate level of reliability and validity to classify the thoracolumbar and take appropriate treatment measure against them. before 2015 is a rehabilitation system when used by expert. This is before 2009. This is positive assessment for thoracolumbar injury classification. The worldwide limited adoption due to the perception that the treatment bias of its developer and does not accurately represent the accept treatment algorithm in any parts of the world. So this is negative statement. And the PLC complex score was the least reliable component because it's necessity of MRI. And during emergency, there is a limitation for MRI. The epilepsy status is undetermined. The rotation injury for score three score with intact PLC and intact neurology does not require surgical stabilization, but in AO classification type C, more unstable than distraction injury. This is negative statement. Concern to burst fracture, because in L1 fracture with compression and burst fracture injury, 1 and 1 point, and intact PLC 0 point, and intact neurologic status 0 point. TLECS of 2 no operative. There was 20% loss of height with kyphotic angulation. This is concern about this classification. Despite randomized trial uncertainty regarding best management of patients with intermediate severity burst fracture. So this is a negative statement for thoracolumbar injury classification. Now, if you compare with the new AO classification, the new AO classification correct terminology of spinal parameter and therapeutic algorithm, essential professional communication treatment recommendation can help to make accurate diagnosis through a correct assessment of the fracture morphology, shows that the important morphology modifier for decision making, disturbance of sagittal or coronal alignment, degree of vertebral body distraction, stenosis of spinal canal, and intervertebral distillation. New classification broadens the most rational classification which represent a gradual progression of morphologic injury using which the extent of instability is determined. A higher category indicates more severity, thus greater instability gives an indication for type of treatment and prognosis. It provides an algorithm for radiologists and clinicians, can be made concise, handy, and easy to use. This journal gives an simplified algorithm for treatment. This is give a positive statement for the AO classification. Another statement, good inter and intra-observer reliability of the AO spine, thoracic spine system has been demonstrated. Ensure that there was no variability in the interpretation of the case presentation. This is give a positive statement. The new AO classification, in conclusion of the existing study with the highest level of evidence, a clear recommendation regarding the treatment, operation vs conservative. The therapeutic recommendation in this article have proven to be helpful for daily practice in several German spine and trauma centers. The morphological modifier might be considered in further research project to evaluate their impact on daily decision-making and outcome. In the future, more differentiated evidence-based therapy algorithm will be hopefully available. This part of the assessment is positive. So the new AO classification criticized the existing classification because it's too complex to use in routine clinical practice and did not suggest treatment option. Also too inclusive, besides complex, cumbersome, the reproducibility is a matter of concern. This gives a negative statement for the AO spine. Let this summary the statement, positive and negative, combined between the two latest classification. If we see the correct terminology, then the AO's classification according to the review article is more positive than the first one. The accurate morphology is more the better in the new AO classification. Recommendation treatment in first previous classification is better. Assess severity is better in the latest classification. Inter and intra-observer reliability, according to literature before 2015, is positive. But after 2015, the AO is more positive. Also, the validation in interpretation, the AO is positive, easy to use. In AO classification is a little bit complex. Complex to use in the clinical practice, yes. PLC complex injury termination is difficult in previous classification, but very good in new AO classification. Worst fracture determination and very good in new AO classification. The conclusion is the latest review article showed that the new AO classification indeed more complex, but comprehensive morphology, the higher type, subtype, the more severe the injury, then easy to determine management. Thank you. Yes. This is actually the summary of the statement of all the...
I think this is not what we wanted to have. Actually, you should have created...
You can make this summary as a statement.
We can make two statements out of that summary. So if we go into... okay, maybe from this we can make two statements.
This?
So maybe we can make two statements out of it. And we say that both TLEX and AO classification are reliable and are used universally. So you can have one statement saying that both are fine. And depending on your circumstances, you can use both. People who have everything can do that. And second, you could have that in recent studies, it has been shown that the new AO classification has got, can show more comprehensive morphology.
Sure. Let's write it here.
Mm-hmm. Yes.
So we can have the first statement as Imad, can you go and type over there and help?
Yeah. Yeah. Right.
So
right.
Statement 1. Both AO and TLEX. So it has to be actually you have to say sorry, new AO. And TLEX are reliable classifications of thoracolumbar of traumatic thoracolumbar fractures, traumatic thoracolumbar fractures, and are widely used and are ARE. Widely used.
Widely.
Okay, second statement. Statement 2. recent review, not review, recent literature has shown that new AO classification, despite being more complex, can yeah,
Comprehensive morphology.
Can be helpful in treatment, in diagnosis and treatment. Yes, yeah, it's fine. In management, yeah, you can remove diagnosis and treatment and say management is fine. Both are same. Fine. And then just well, let's vote on two statements. That's okay. So then delete rest of it. And management of thoracolumbar fractures. Okay, just complete that.
Mhm.
Yeah. Okay, and then delete the rest of the thing so that we are clear that we're just voting on two statements. Okay, so let's get it and vote on statement 1. Can we vote on statement 2 then? Okay, great. Thank you, Hafid. Nikolai, you're next.